So welcome everyone. I'm going to show you a couple of things that we are doing here at the University at Buffalo involving our 3D CAD/CAM technology that we use in the clinic and in the pre-clinic in order to train our students, and also some of the 3D imaging, video imaging that we have in order to teach our students in a more friendly environment, we'll say, an environment where we can actually evaluate student work and give feedback in real time, whether we do it over Zoom or we do it live and in person. So I had students throughout this past year coming to see me to evaluate their preparations, and one of the things that would happen in the past is the students would bring the preparation and I would look at it under my loops. I would be able to see some deficiencies in the preparation or areas that needed improvement, and I would describe those using dental terminology to the student. The student would then be able to take it from me and evaluate that themselves, see if they kind of understand what I'm saying. One of the things that we've been able to do that's been a nice benefit using our 3D camera is that with the 3D capable glasses, we are able to see this together simultaneously, and we're able to evaluate the work together as well. So it becomes a really nice tool when I want to show a student what I'm working on or what they need to improve on. We can actually look at this together in a 3D camera and see where some of those improvements need to be made in the preparation. We can zoom in or out in order to see different aspects of it. This is very bright right now, but let's see if we can turn that down just a little bit. Yeah, so we're able to evaluate this. One of the other things that technology that we have not used for our students, but actually is available for clinicians in private practice, is using this in order to do a preparation actually. So many times if I want to show a student exactly what I want them to do in the preparation and where I would like them to make an improvement, again, in the past, I would have to do work while a student is crowding over my shoulder, or maybe 2 or 3 of them are looking over my shoulder to see exactly how I'm approaching this restoration or preparation. With this technology now, I can broadcast this whether it's to one student or a group of students that are here, or live over a Zoom. So when I bring this camera into position, I can actually show the students on the camera exactly what I want them to do. So as I'm preparing here, or working along this 2 structure, or trying to show them how I would create certain areas, this can all be done on a large 3D camera in order for them to be able to not only evaluate the work, but in order to see exactly what we're doing intraorally. So this has been a really nice tool, and again, something that can be used clinically, especially for patients that are maybe harder to work with. We have a nice large view. The only thing that makes it a little bit more challenging is that the interface is reverse what you think it would be, because it's actually left is left and right is right, and normally we're used to looking at ourselves in a mirror. Anytime you see your own hand, it does make it a little bit challenging to kind of do the opposite of what you've learned by using a mirror your whole life. But it really is, it has been an extremely nice asset for us. This is developed by Dr. Mora in California, so this is a MoraVision that we use, and we have 3 of these cameras right now on loan for our students to be able to use for teaching purposes. So this is one of our 3D CAD/CAM scanners. So we can actually make lithium disilicate and zirconia crowns here in-house by having our students scan the actual patient. We use a model similar to this, the older version, to train our students in the preclinical facility. So we actually have 10 of those available for students. And then we have 5 of these scanners available for our pre-doc and post-doc students. So last year, I think I scanned 15 to 20 single unit crowns and actually 2 bridges with students. We were able to actually cement them on a patient at the next visit, which was really nice. So I'm going to go through how we actually do the scanning for our patients. We have that same fake model that I used on the Moravision and our Typodont, or our mannequin. So we're going to do this scan. Normally, again, this would be done intraorally. After we pick the tooth that we need, this is a pretty easy process, so we're going to go to the scanning page. So when we get to this page and we've got our scanner ready, we're going to pick the lower arch that we want to scan. This is actually the arch that has the preparation on it. With the wand, this has a high-def camera basically, and it's going to take a series of pictures that actually creates almost a video and a 3D image of the tooth. And you can kind of hear it working as we scan. And the nice thing about using these scans, when we did traditional crowns, and they're still made, very often there's a lot of distortion that happens with the impression and with the models. And a lot of that distortion is compensated for by the material. So when we have an area that's distorted on the model and we have an area that's distorted on the impression, sometimes they will balance out. So during the investing process of actually making the crown, there's some shrinkage of the material and there's some expansion of a different material, and that all cancels out to give us a crown that usually fits. This process really streamlines it because we have a true one-to-one representation of the tooth, so the lab can actually make a very accurately fitting crown. So now that we've scanned the lower and it's that quick, we've got the arch that we've scanned and the tooth. And this actually gives a video kind of colored image as well. So now we're going to scan the upper the same way. And basically what you do with these scans is scan the occlusal surface, or the top of the tooth, and then we're going to roll it over and scan the buccal, and then we're going to roll it over and scan the lingual. Now for the opposing arch, really the important thing is an accurate representation of the functional cusps, which on this case are on the side of the palate. So once we have a pretty accurate representation of those, we can stop. The next thing that we need to do is get the bite. We need to know how these teeth come together in a three-dimensional space, how much room we actually have. And the computer will map this out for you when you make kind of a zigzag back and forth. It'll lock these in. Or at least it should. Oh, there we go. There we go. All right, so now we're locked in. So this is actually how our teeth come together. This is a really accurate representation of how they fit. And one of the things that we can do that's actually really nice for our students, because a lot of times they have difficulty evaluating the amount of space between the teeth. Obviously, when the patient's biting down, if the tongue or the cheek are in the way, it becomes a little bit more challenging to really judge that distance. we have the ability now with a quick scan to be able to evaluate this in that three-dimensional view and really see if there's actually enough space for the material that we've chose. So when we've got this final scan now, it'll actually look even prettier when we go to the post-processing, but we can eliminate the maxillary arch and we can bring in the clearance. And what this is going to do is it's going to show us how much room we actually have. So we can change the parameters. So right now I want to make sure we have at least 1.5 millimeters of reduction all the way around, which we do. We have one little spot that might be like 1.7 millimeters. In certain areas, I want to make sure we have at least 2 millimeters of reduction, depending on the crown that we've chose. So in this case, we actually only need 1.5. This is for a zirconia crown. So we actually have enough occlusal clearance all the way around for this crown to be made out of the material of choice without it risk fracturing. At that point, we would process this, and then we'd be able to send this to the lab for design. Many offices will design this on their own. We actually have lab techs at the school who will design the crowns for them, and usually the students will go and watch that process happen. If we had a situation where we realized after the fact that we didn't quite capture this area, or let's say we had to reduce a little bit more on this mesial buccal portion of the tooth, we can actually go back to the scan and we can delete a small portion of this. So let's just trim this area right here. And what we've done is we've removed that portion of the scan because that was the only portion that was edited. The rest of this remained the same. So to go through rescanning the entire thing can be somewhat of an arduous task for the patient, especially if it took more than 30 seconds to scan it. But at this point, if I've only edited that one spot, I can go back in and now just rescan that one area very quickly, and it'll splice that back together for me. So now I have an accurate representation of that area that I changed. It makes it much more convenient for the patient, as opposed to impressions where if we had a small spot in the impression that wasn't perfect, you have to redo the entire impression, which means the patient's sitting with impression material in their mouth for another 5 minutes and then evaluating that one. Very often we try to keep one custom tray, so one tray that's been made for the patient. If we have an impression that just has one tiny defect somewhere that isn't important, we may use another tray to take the impression, and now the lab has to somehow bring those two together to evaluate and make a crown for the patient. So this has been a really nice tool that we have for our patients in order to be able to make crowns for their patient clinically. And again, we use these technologies in the basement to help the students in learning and evaluating their own preparations as well. So this is actually our post-processed view of this crown. So this is what the lab is going to get. And you can see how incredibly accurate this is when we compare it to the actual model that we saw on that 3D camera or the 2D image that you're going to be seeing. It is an extremely accurate image that also gives us some coloration. So we have an area here that's slightly subgingival, so it's slightly below the gum line. Normally we would retract the gum line out of the way so we can actually see this area of the tooth a little bit more clearly. But even without the gum tissue out of the way, we have a very nice view. Even this one area here where the student had a little discrepancy, it's not 100% perfect. Clinically, I don't know if I would be able to evaluate that as well as this can. And again, the lab can make just a perfect fitting crown to this preparation because this is a true representation of what the student created. I think that's all I have. If anyone has any questions, this is obviously a recorded presentation, but I am now here live, so I will answer those for you. Thank you.